Welcome to Smartlife. My name is Dr. Mena. Joining me is Dr. Georgiy Brusovanik, spine surgeon. Good morning, doctor.
Good morning, Dr. Mena. Great to be on the air with you.
So as a spine surgeon, what will be the utility of spinal injections and the role for deciding surgeries?
So spine injections serve two important purposes. First and foremost, these injections allow vast majority of patients with severe sciatica, with severe back pain, with neck pain to avoid surgery. You see, as disc degenerates, there is an inflammatory component, and then there's possibly a compressive component as that disc starts to encroach on a nerve. Once a nerve is irritated or compressed, a patient will feel pain in the direction of where that nerve travels. So, for example, sciatica is nerve pain due to either compression or inflammation. Well, since inflammation in vast majority of patients is the major contributor, an epidural steroid injection that delivers steroids will diminish inflammation and essentially take away the patient's pain. Since the problem isn't dangerous, if a patient isn't suffering from disc-related pain or nerve-related pain, then they usually do not need surgery. But there's something else that's very important about these injections. Imagine as you age and all the discs degenerate, and then you come to the doctor saying you have pain. How do I really know with certainty which exact disc is causing the problem? Well, it's because of these injections. You try an L4-5 epidural and the patient comes back and says, "Doc, I had no pain relief." And I tell them that doesn't mean that you have to rush into surgery. What that means is that that is not the cause of your pain. Now, the corollary to this, you do an L5S1 epidural and the patient comes back and says, "Doc, I had no pain for a month, 6 months." And I tell them really with high level of happiness and satisfaction that not only are we trying to avoid surgery, if your pain comes back, I now have proof that the pain comes from that very same level. So essentially, injections correlate imaging with the patient's pain. And then when we do go to surgery in few cases, I have complete confidence that the patient will get better. I have complete confidence that the disc that I'm going to address during my surgery is exactly the cause of the patient's pain.
That's very true, and actually I will chime in. These injections, first and foremost, they need to be done by an experienced physician. That's number one. Number two, normally you have to use the aid of X-ray guidance in order to deliver and target the right source of the problem. That's key when we're doing this type of injections. Also, there's a lot of injections that we do into the spine. Namely, when we talk about epidural injection, the best injection in order to accommodate and know where the problem is a transforaminal approach, or some surgeons, they call it the selective nerve blocks. So those injections are very target specific. They serve as diagnostic and therapeutic purposes, as you well said. And sometimes they can spare from a surgical interventions in most of the patients. Unfortunately, some patients that they might not, and at least we got what we call the pain generator. We know where the source of problem is. And most of those, whenever they go for surgery, from the surgeon's perspective, they know the target area. So I agree fully with you what you're saying, and yeah, the injection is the first route, and normally it's the way that we can confirm what we're seeing on an MRI where the patient's pain is coming out from. The MRI shows a lot of stuff, but not necessarily all the stuff that you're seeing there might be causing the pain. So let's talk about another topic. Nowadays, we hear about a lot of disc replacement surgeries. Traditionally, we know that for someone with a segmental type of pain, like coming out from a disc, not a disc herniation, rather than the discogenic source of pain or internal disc disruption syndrome, typically a fusion traditionally has been the type of surgery that has been done for many years. Nowadays, they come to disc replacements. A lot of patients, they have a lot of questions about the disc replacements. What's your take on the disc replacements versus a fusion?
You know, a fused spine is not a normal spine. So if there is deformity, if there is severe pain from a segment that limits a patient's quality of life, then it's reasonable to consider a fusion surgery where we essentially stop the painful motion at the segment. but a fused spine is not a normal spine. So over the past 50 years, there has been major innovation in attempting to maintain motion. And disc replacement surgery essentially is the culmination of maintenance of motion, motion preservation. So the approach is minimally invasive. You still get rid of the disc that's causing a problem. You can still recreate normal anatomy, yet there are no screws, there are no rods. And for a typical young patient, and young, I mean someone from 20 to 70, where there isn't a lot of deformity, there isn't a lot of disc collapse, if I can sneak in, restore the disc height, and take away the painful disc, they wake up and their pain is gone. It's really rewarding. It's not without risks. And it's important before disc replacement surgery that we ensure that the patient has good quality of bone, that the vascular anatomy is reasonable. But for the most part, disc replacement has really changed the way I practice, specifically for that group where they have severe life-altering pain, but not significant deformity warranting a fusion surgery.
So what type of innovations what might you do in order to increase the safety of this type of procedures that nowadays are coming from a minimally invasive approach?
That's a great question, Jose, because we talk a lot about doing better with instrumentation, doing better with implants, but we don't talk enough about the safety of the approach. How do you get to the spine? The human spine is in the middle of the body. So whichever way you take it, there is morbidity with the approach. So first and foremost, we have learned to reach the spine using tubes or tubular retractors. We have improved lighting inside the tube. And now as I look through the tube using a microscope, I can essentially see the differentiation between tissues very well. We have also learned neuromonitoring techniques, and that's when nerves are hidden deep inside the muscle. As a spine surgeon, I worry about touching that muscle or touching that nerve so as not to cause injury to the nerve. Well, now I can just gently probe that nerve with this it's like a pencil kind of a device, and looking at a monitor, it will literally tell me my proximity to important neurological structures, thereby allowing me to spare the patient the inadvertent risk of compressing or even injuring a nerve. Then there is navigation. We have learned to use intraoperative CT scan and robotic instrumentation to correlate what we see deep inside the patient without having to open the patient's body. That means that I can place a screw to hold certain elements of the human spine together. I can place that screw through a tiny incision without having to make a big hole, create cavity, and thereby causing a lot of pain. So navigation has been just a godsend, not only because of lowering the morbidity of the approach, but also improving the precision. We have statistics that show that somewhere between 1% and 5% of screws that are placed during spine surgery may be malpositioned. Even one screw is one too many, because that means that the patient will have pain. So if a surgeon does over 100 operations a year, that's at least one complication per year. So the navigation techniques allow us to improve that precision to 99.9. You could really see where you're placing instrumentation without making a big hole. And I can definitely see an improvement in how patients feel, how quickly they recover.
Very interesting what you said. And how about any other newer minimal invasive approaches that nowadays we're doing right now as compared to the past? Any other surgical techniques?
Absolutely, that's a great question. So these new approaches, quote unquote, minimally invasive approaches, have really allowed spine surgeons like myself, a lot of younger surgeons are really well versed in these methods. They allow surgeons to reach the spine from various angles, thereby minimizing morbidity. For example, the classic spinal operation opens the back, and to do that, you have to move the muscles from the bone. That means injuring muscles, cutting muscle, and in a patient with back pain, that's a problem. So we have learned to reach the spine from the side or from the front, where it's possible to do it without injuring tissues at all. In fact, the approach where we reach the spine from the side usually results in almost no blood loss. These are the new minimally invasive techniques, but I would just stress that obviously you'd want the less injurious approach. You'd want an approach with less morbidity, but it's important to really maximize conservative care. And once you've decided on an operation, please make sure and talk to your doctor about the risks, about alternatives. These questions will allow you to make an educated decision and really prepare you for what happens after spine surgery, really allow you an opportunity to also get to know your spine surgeon as you're about to embark on a potentially dangerous battle.
Very true, and very interesting things that you just brought in. Lots of learning, and actually, I hope that the viewers and audience, they find this very helpful. And again, I will thank you for joining me again in another segment of Smart Life. Thank you, Doctor.
Thank you, Dr. Mena.